now. Welcome to today's session. Again, everyone is in listen-only mode. You may type questions into the chat at any time. Please do send any questions to all participants so that everyone may see both the question and any response that is typed. If you have a technical issue, please send your issues to the host only, which is myself, and I will address them. We'll take questions later on in the session, and we will be able to unmute lines for live questions. We will explain that process when we get to the question portion of the presentation. So with that, I've turned it over to Tyler Hausman for introductions and commencing today's webinar. Tyler?
Great. Thank you, Fran. Good afternoon, everyone. Thank you for joining us. This is the second series of monthly webinars for the Garden Practice Transformation Network. I'm Tyler Hausman. I'm the Senior Director of the New Jersey Healthcare Quality Institute. The Quality Institute is a multi-stakeholder organization that convenes healthcare leaders in New Jersey around the common goal of increasing quality and reducing cost. We're partnered with the Garden Practice Transformation Network to bring you learning activities that support the transformation efforts of practices enrolled in the program. Learning activities will highlight content experts from within our membership that can offer best practices, help you strategize and prepare for the changes that are happening as we move toward more value-based care. And today's topic is risk stratification. Risk stratification is defined as an approach for identifying and predicting which patients are at high risk or likely to be at high risk, and prioritizing the management of their care in order to prevent unfavorable and costly outcomes. And so the member that we're highlighting today is Continuum Health Alliance. Continuum is a physician enablement company that fosters self-sufficiency among provider groups by maximizing fee-for-service reimbursement, transitioning them to value-based programs, and preparing them to participate in clinically integrated networks. And our speaker for today is Bryan Wellens. Bryan is the Vice President of Value-Based Intelligence at Continuum Health Alliance, and Bryan oversees population health operations and administration of government and commercially sponsored value-based programs. He develops data-driven strategies in collaboration with key leaders, stakeholders, and clients, delivering actionable patient-centered information that helps improve the patient experience, increase quality, and reduce overall costs of care. And so with that, I'm going to hand things over to Bryan to talk to you about risk stratification.
Thank you for the introduction, as well as the JII and New Jersey Healthcare Quality Institute. It's a great opportunity to talk about population health and context of risk stratification today. So the items we're going to go through, it's really pivotal for cost of care and utilization management for populations which we serve. And it really comes down to the patient, outlier patients we can identify, as well as the entire population will be successful in value-based reimbursement models. So topics and themes which we're going to go through today is population health management and how can we leverage the data for actionable insights. How populations are defined and ultimately attributed to the providers for which we're ultimately responsible for the care. Riskification, when we're leveraging the data, what does it mean? What types of models are commonly used? And why it's important? And then we'll look at some case studies here so we can the power of leverage data to deliver optimal patient outcomes. Within that, there's going to be themes throughout the presentation in terms of what steps as a provider you can take to realize the impact of risk stratification. As alluded to, population health is really about proactive patient management and looking for those outlier opportunities, we can leverage it. So there's going to be some key takeaways and things that come along, and please feel free to type in any questions throughout the presentation that might come up, and there will also be some time at the end where we'll answer some questions you might have as well. So with that in mind, thinking about population health and healthcare analytics, they're not mutually exclusive. One of the most important things we want to do is understand what the definition of population health is. There's a lot of definitions out there. Ultimately, they have common themes in them, whether it's with regard to health interventions, determinants of health, or health status improvement. Health is commonly defined as receiving the right care at the right place at the right time, with the ultimate goal of improving health outcomes. We ensure that patients receive the lowest cost of care with the highest quality. So when we think things like health interventions, it's anything from things that we can do to prevent some things that are happening. So, for example, the Center for Disease Control has estimated that 80% of heart disease and stroke patients, 80% of type 2 diabetic patients, and 4% of cancer could prevent it by doing simple things such as stop smoking, start eating healthy, getting in shape, eating in moderation, some of these things that we can intervene in the care. In terms of determinants of population health, there are things that, such as the physical environment, there's education, there's employment and working conditions, income and social status, a lot of things that can determine the health. Only when we look at that, it's what activities and the things that are fitting to that, which we can focus in on, think of the root cause of that, and then hopefully intervene in them, and then about some of the activities for health status improvement. In mind with that goal, data which we can help drive us to make actionable decisions. So the area of healthcare analytics, if you look on the graph to our left-hand side, it's really about taking data, turning it into information, and that'll end up being our knowledge base through which we can have the infinite wisdom through which to make decisions. So when we think about it from there's the descriptive, what happened? And then also the diagnostic, why did it happen? So for an example, cost of care could have gone up by 10%. We want to see why did it happen. It could have something to do with the location of care where patients are receiving care. It could be an anomaly of patient outliers who just had advanced acute episodes of care, so we drill down into that. It could be an attributed population issue. Something as simple as here's 100 patients who are attributed, but do they have a primary care physician or are they considered medically homeless? It could be around frequent flyers to the ED or even multiple hospital admissions and readmissions. So the type of things when we look at to describe what happened and why did it happen. Then moving up the chain here, we look at predictive analytics. Those are the things that can help us predict what happened based on the data we have available. So if we're able to identify that 10% of the cost of care went up, then we can look at our patient population, their utilization metrics, things around their demographics to say, okay, here's what we can predict will happen, patients who have similar variables that present in them. So in terms of being a provider, we often do case studies, and we look at the patients that are treated to us or the patients that we're seeing on a daily basis, and it's almost like the grand rounds for which we look at it. We can say, okay, here's what happened, here's why it happened. So we use the data, information that we have in front of us to predict what's going to happen in the future, and then ultimately prescribe, how it happened, but from that prescription, how can we help prevent this in cases who might show up in a similar fashion? Taking that in mind, that's where population health, the concepts of optimizing patient outcomes, and then taking the data and then putting this process in place from descriptive, diagnostic, predictive, and prescriptive in place so that we can ultimately think of the populations that receive those outcomes. It really comes down to population health is all about the patient. So we need to first understand who the patients are and how are they attributed to. Attribution is a term that can be used a lot of the time, and it's, well, what does that really mean? It comes down to who are those patients based on a plurality of care whom you see all the time who are ultimately, you're ultimately responsible for their quality, cost, and patient experience. So if running through this, so looking at this, if we have the patient who presents over here, and then we see that are they seeing they're seeing multiple providers, a primary care physician, they could be seeing a specialist, they could be seeing multiple specialists. So this patient, an example of seeing multiple providers throughout the healthcare system. It could be patient utilization, outpatient utilization, and so forth. So, for example, the patient could have a $100,000 spend in a given year, and ultimately, they're attributed to one of those providers who is considered the attributed provider. Most often, it comes down to the primary care physician. Some rules around attribution are total visits to a specific provider, as well as total charges. In this model, it's almost the keeper model of that, where I might be the attributed primary care physician, and I have only been reimbursed $5,000, however, ultimately responsible for $100,000, as I was sharing. We're also responsible for the quality of gas enclosure for that patient. It could be a diabetic patient who has hypertension. So look at those quality metrics that could be attributed to that patient, there's things such as HbA1c needs to be meet a certain threshold, whether it's under 8.0 or under 9.0, in a specific population. It could be something around the LDL-C measure. For a hypertensive patient, 140/90 is generally considered the threshold for which a patient is controlled. If a patient presents at or above that, they then have a gap in care. Now, some of this is the HEDIS or the PQRS national definitions and benchmarks. When with that in mind, those are thresholds which they set. When seeing patients, we might need to make some customizations to that rule because a patient might have a higher blood pressure, but they're in other areas, so as long as the physician is on top of that. Moving on. Now that we understand who the patients are and how they're attributed to us and why I'm ultimately responsible around them, we use something called risk stratification. Risk stratification is the process for identifying and predicting which patients are at risk or likely to have a high risk or be at risk for future cost and utilization in the future. The data elements or variables that we take into account for which we put cohorts into certain categories, which we'll share a little more insight into a little bit later. We look at things such as patient demographics, whether it's age, gender, socioeconomic status. There's diagnostics that we can pull into, whether they're chronic or acute. We look at the ICD-9, ICD-10 codes. We look at patients whether they have multiple comorbidities or not, and we look at behavioral health indicators. There's patient risk, and we look at this and try to benchmark some of it as well. So we get a given patient or a population. If it's $10,000 on a given patient, are they benchmarked against $20,000, for example, based on the multiple comorbidities or even their patient demographics? One of the things that is out there is that a zip code can be the highest predictor of utilization and spend. And that is something that we'd want to put into that risk stratification algorithm or model for consideration. There's patient motivation and compliance. There's the PAN scores that you can utilize to say, as a patient, if they're identified, are they likely to engage in their care and be a part of that care team as opposed to be the episodic patient? So we want to proactively engage and enact those patients, especially depending on their diagnostic classification or even some of the demographics we can take into account, and then factor that into, if we've highlighted these patients, are they likely to be able to receive the care that we actually offer to them, whether it's produced through a care plan or even it's the healthy population who we just want to bring in for an annual wellness visit. In compliance, there's things such as medication reconciliation that comes into account there as well. Patients might be prescribed a medication, but how many of them are likely to go and get that prescription filled? In addition to that, even if they were to get the prescription filled, how likely are they going to go and refill it? There could be that prevent them from being compliant. There could be patient access issues in terms of, are they able to get the right care at the right place at the right time? The primary care physician's office might be closed, so they decide to go to the urgent care center or the emergency room. So we take all of these things into account for when we're looking at risk stratification and some of the scenarios I may present.
And we saw a question come in for the host. If everybody wouldn't mind, when you submit a question through the chat box, just make sure that you submit it to all participants or all attendees so that everybody can see the question that you've asked.
So what I'm referring to there is that when we look at population, they're usually going to fall into four primary buckets. And percentages that you see on the slide here, they're general. They could flip up and down a little bit, but they're generally in that area. So if we're usually going to have patients who are healthy, they're low risk, rising risk, or even high risk. If you look at this, there's certain things that we're going to enact in that patients for whether it's a healthy population, maybe it's an annual wellness visit. For the low risk population, who counts about 25% of the population, there's some of the care prevention that we can go to there in terms of we need to make sure patients get flu vaccinations or pneumonia vaccinations or what those type of preventative procedures could be that they'll qualify for, colorectal cancer screening. Some intervention, this is the rising risk population, and we'll talk a little bit more about them and what that means, but to these patients that we identify who are likely to end up in the high risk bucket, or the patients who might have an acute episode of care for which they end up in the hospital or utilize the system frequently, whether it's in the emergency room or need specialists and so forth. So one of the things when we identify that rising risk population, to make sure when they're going to use the system, it's going to be at that right place, right care, right time. To put in context, we're going to drill down to our sickest patients. When we look at the healthcare system, it's around $3 trillion a year in spend. And to take that into account, there's 15 to 30% of wasteful spending or unnecessary spending that could happen, whether it's through overutilization of certain ancillary services or whether it's patients who are going to the wrong places, such as if they could have gone to their primary care physician's office for a visit, well, maybe they ended up in the emergency room instead because of the access issue. So there's things of that nature that we can look at. With the complex chronic patients of the population, it's around 25 million people with an annual spend over $300 billion. Their annual per capita spending or spending per person is over $12,000. To put in the context, the average spend per person in the United States is around $9,000 to $10,000 per person per year. It's an outlier when you look at other around the world, but that's where we're sitting at. So when we think about when we're going to cohort patients, we can look at those complex chronic. To that a little bit further, out of those 25 million or so people, about 20% of them are actually going to be in really the complex chronic in terms of the top spenders. And this cohort of the population, the 20% or so, are actually spending around 70% of all the spending in that category, or 70% of that over $3 billion. Annual visits in this category are 29 visits per year. Now that can be of multiple different providers. If you think about the attribution model that we talked about, they might be seeing specialists, it might be seeing a primary care physician, multiple specialists throughout the system, whether it's inpatient, outpatient, professional care services. Compare that against other complex chronic patients who have 13 annual visits a year. This is a cohort of a cohort, and we can see that this group here has 14 chronic conditions per patient on average. Down a little bit further, we can actually distill down into the patients who have COPD or asthma. So that those are specific chronic illnesses that this patient population has. Group, that accounts for 55% of the spending. And when we the determinants of health, and this is where we're looking at here, where we're aligning the data with actual types of patients they are, we can, and the determinants of population health, we can see that their needs are concentrated in some primary areas, whether it's social, access, or behavioral health. 2.3 million of this population is unemployed. 81,000 patients or so, are having difficulties of accessing care. They need it. Right care, right place, right time. And that, if you look at some of the behavioral health issues. Now, this is an example of how we can use data to start distilling some of these cohorts or risk stratifying them. If other data points that we can bring into whether it's the cultural, demographic, environmental, or community social, in terms of are they able to get to their provider if they need to? Is there transportation to get them there? So there's a lot of items that we look into when we're talking about population health, the data available to us, and the data that's ultimately going to be leveraged to make those actionable decisions. And then find that 15 to 30%, overall wasteful spending opportunities. Ultimately, it's about the patient and making sure that they receive the lowest care with the highest quality, as we shared a little bit earlier. So, moving on, here's some terms you might recognize or hear from, whether it's in current programs you're in or future ones you're going to get into. With the fee-for-service world of medicine in terms of payments based on volume, it's now moving into, and very rapidly, into a value-based payment modality. When this is accounted for, it's not necessarily the patient today and what you're going to be getting paid for them. It's also going to be around the patients who are attributed to, around the cost of care, the quality, and then with the patient access or patient satisfaction. When we look at these, there's a high risk models you might, or methodologies that you might hear of or understand. There's a couple different models. For example, there's the hierarchical categories, or the HCC ACCs. This is a model that is actually publicly available and it's released by CMS. They place patients into condition-based categories. There's two pieces to it. You might commonly understand it or refer to these as being used in the Medicare Advantage programs. So they look at the entire population who might be attributed to you or you're responsible for and come up with the ADC for each of these patients and associate it with a risk score. And then they rate that risk score and ultimately say your patient population average risk score is 1.05 versus everybody else for a baseline of 1.0. So meaning your population is here than the next. That's how some of these get used into it. There's also the commercial-based model that's in there as well for some commercial plans. And to give you an idea, Medicare for that, there's actually for the commercial model, there's 127 HCC categories currently, and for Medicare one, there's 79. So there's different models, the way they apply them, but it's condition-based. And then there's the ACG, or the Adjusted Clinical Groups. This is commonly referred to as the Johns Hopkins model. They developed it there, and it's really around the morbidity burden of patient populations based on their age, gender, and disease patterns. What there is they'll develop a case mix which captures the severity of utilization. There's over 100 discrete categories, and what happens is they then get developed into aggregate diagnostic groups, and there's 32 clusters of them. That's a detailed way of saying they look at the patient population and they do something similar to the HCC model where it's condition-based and they try and look at the spend and utilization. There's also episodic treatment groupers, which is commonly used by healthcare plans, and there's a lot of vendors out there who actually take the concepts or methodology which was created and they create proprietary algorithms around them. Familiar with episodes of care? More or less what it does is it takes claims and encounter-based data to describe those episodes of care. For example, if a patient goes in for a hip replacement, then they'll take into account anything from the beginning of that cost and care utilization over a time period. Day one, they'll visit the primary care physician, they'll go and they'll get the radiology work done, and then they'll go and get the surgery, the pre-surgery prep, where they have their anesthesia, the surgery itself, and then any follow-up work it has, and look at that entire episode of care and say on average that was worth $5,000. And they'll see where those utilization patterns go into it, but then they'll also look at the severity of conditions of patients that are going into it. So to summarize this slide, there's a lot of models out there. You might have heard about them, you might be included in them, but if you're in this value-based payment world, it's really important to understand which model you're ultimately going to be judged upon for the risk of your population. You see your risk score, there aren't any surprises. What we've seen anecdotally in working with a lot of providers is that we'll show data and they'll say, the data is inaccurate. My patient population is so much more sick or so much more risky than what you're currently showing. There's two ways to really think about risk in this scenario. There's risk score optimization. See a patient, they present to you in your office, and have problems on their list that are active, and the patient comes in with a cough or flu. You're making sure you treat them episodically, but if they have currently on their problem list have diabetes and hypertension and CHF and COPD and whatever those current disease burdens are, you want to make sure that that actually gets on your bill, it's communicated to the payer, whether it's Medicare, it's commercial, or something else, and ensure that when it's on the bill, it gets to them, they can reflect that in your risk score. Otherwise, if you don't report that, then they're not going to see it and understand it. There's also time periods around this as well. You saw a patient last year. When you see them this year, you got to make sure you flag them again with the diabetes or whatever diagnosis they have. So it gets really detailed, but in summary, just think about what the risk models are, how you can optimize that risk score to truly reflect the patient population you're seeing, as long as it's within the confines of, the things that when you see the patient, you're not doing anything that's unethical or immoral by just adding codes to a patient when they really don't exist.
Question come in from Winnie.
Sure.
I think you may have answered it, but what about the Medicare Advantage patients who tend to be the sickest patients? They are not calculated by Medicare-only carriers.
So with regard to the Medicare Advantage models, and they are commonly using the hierarchical condition categories. So to answer the question, I believe we went through some of it. The Medicare Advantage models will use that, and to accurately define the risk of that population, it's really when you see the patient and then make sure they're accurately diagnosed. Because that's when the conversation between the provider and the payer, it's really through those bills, those paid claims and bills. And it's not only if I'm the attributed provider, what I'm seeing the patient managing, if the patient goes on vacation and they're getting sick or wherever else and they end up in the hospital, there's other diagnoses that will come on that claim. But only as that gatekeeper model, I'm the attributed provider, I need to understand which diagnoses are out there. So we can come back to that a little bit at the end if I didn't fully answer that, but it's really around patient comes in, making sure accurately diagnosed if the active problems on the list, making it gets communicated to the payer through a claim, and therefore it will reflect in the ultimate risk score. And in terms of the Medicare Advantage models, that is, risk score is a lot to do with their ultimate payments that they receive from a capitated model. So why is risk stratification important? With these value-based payment models, and the example of the Medicare Advantage, it's the riskier population, and it's sure that's communicated properly. So if you look at here, these are all patients down here, and we talked about the healthy and low-risk patients who account for about 75% of your population. Then we have our rising risk population, who's about 20%, and high risk, who's about 5%. So if you look on the cost continuum here, on the right-hand side, you can see these are your patients who are high risk or have had acute episodes where they had a really high spend on utilization. In population health and managing those populations, we focus in here on all the populations and making sure right care, right location, right time. But rising risk to 20%, which we can start looking at some of the preventative things. There's people we found to have been a couple $1 million that life event happens, there isn't something you could have done. But there are other patients who might have uncontrolled diabetes that exasperates into something else. So these are the type of things we'll look at when we cohort the patient populations and look for the data to see where there are opportunities lie, especially when it comes down to the patient and focusing on them in terms of that are going to make them happy, healthy, and live longer lives. A little bit closer. Again, we have the same types of cohorts or high-level population cohorts here in terms of healthy. There's 50% of them that fall in this bucket, and they're spending about 5% of the care, or the total cost of care. Other spectrum, high risk, or the top 5% of the population account for 50% of all healthcare costs. So in terms of the rising risk and the high risk, or about 25% of your patients, only a quarter of them, they're paying for 80+% of all cost of care. That shows what population health looks at, especially when we're in this $3 trillion business and looking at for some of those opportunities. Just in the context, health today is 17–18% of GDP, or the gross domestic product, in the United States. 20% of our personal income, on average, across the United States is being spent on healthcare. So it tells us there's opportunities for find where is over-medicalization caring, or even the over-utilization of certain services to patients who aren't getting treated at those right locations. Moving further, so what are the things that, as a provider, that we can do? So first, you want to identify and prioritize our patients and start putting these cohorts. There's a lot of different ways we can do it, from having little data to a lot of data. But we want to be able to use all the available data that we have. And, whether it's the demographic data we might have used for, clinical data, or pharmaceutical data. Claims data we can bring into it, that's fantastic. But if I'm a provider and I'm sitting out here and I don't have claims data in my population, we at least know our populations fairly well. I'm amazed a lot of the time when we're sitting down with providers and showing them their list of attributed patients. The 100 patients whom you're ultimately responsible for. Understand that you probably saw, 110, 120, 130 unique patients. The 10 or 30 other patients, they're attributed to somebody else who they're ultimately responsible for. But for the 100, when I sit down with them, without any claims data, they're able to often tell me even the story of that patient, but the story of their families and extended families to find some of those opportunities. a lot of the time we'll look at that and it's physician instinct and say, I know exactly who my top 5% of high-risk patients are. I know who my healthy patients are. I know all the people in the middle. That's the type of intel that is simple. It's easy to do as long as we have a list of patients to start with. But ultimately, it comes down to identifying those patients, prioritizing them, and placing them in those cohorts of management, and extend out to the entire care team. With that, I want to assess the root cause. Now, a little bit earlier, we were talking about healthcare analytics, and it's really around the predictive and it's really around the descriptive and the types of analysis that we look there. So we want to describe the issue that's going on there. And there's other markers besides the obvious, whether it comes down to standard demographics or diagnoses. We also look at what makes us healthy versus what money is spent on and our active costs. Epidemiology. There's a lot of things that we can pull into their account for when we think about it. So when we look at socioeconomic risk, those things such as the zip code you live in, the education you might have, your levels, the type of income you have, whether or not you have family and social support. There's what are the costs of care barriers that can come from that. Patients are prescribed the medication, but they can't afford it. That's a socioeconomic barrier, which ultimately be a root cause. There's environmental risks that are associated. It's whether it's your physical environment, whether it's the outdoor air quality, in groundwater. There's maybe toxic substances and hazardous waste. These are a lot of the environmental factors that can contribute to effects that can lead to adverse health outcomes, such as asthma. There's poor air quality. Well, you might have a huge pocket in that area, and utilizing that data of patients who have asthma. So that's the root cause. So what are the things that we can do? Behavioral health risk. It's mental health and well-being. Are we doing things such as depression screenings? Is there a social work support network that's available? What about tobacco and alcohol use? Physical activity and diet. So scenarios that come to mind here, and when we look at these root causes, a perfect example we have is in terms of the care team, from provider to case management or nurse care coordination. A patient who presented with one of our populations who had a GI diagnosis, and they needed a colostomy bag. The patient ended up going back and forth to the emergency room. We looked at the data, and they had gone to the emergency room over 30 times in a 12-month period. So once we drilled down into the root cause, it was a patient access issue. So think about that socioeconomic. They call the emergency room on a lot of occasions, or they would call the ambulance on a lot of occasions, which would bring them to the emergency room just to change their colostomy bag. When we did a super visit with this patient and we said, well, why did this occur? Well, they didn't want to bother their family. They didn't have a car, and they just thought it was easier to call the ambulance. Now, that patient wasn't a quality for them in terms of going to the emergency room, when just as easily a family member could have helped them out there, or there could have been access to the primary care physician who could have understood that problem. So then when we look at root causes, we tend to figure out means through which we can satisfy that. These of the frequent flyers, whether it's ED utilization or even hospital admits. In behavioral risk, we found some things whether the patients are just lonely. They're in the emergency room multiple times or getting admitted to the hospitals, just they want to go and talk to somebody. These are some of the maybe not so obvious markers or root cause analysis that go down into in terms of the health stratification or risk stratification. So we'll identify some of that. There's actions which we can take. Think about this almost as a tactical approach. Again, we're looking at the same types of cohorts here overall in terms of our healthy, low risk, rising risk, and high risk patients. Well, there's things such as health education we can do to put healthy behaviors. Maybe an annual visit, and we do some of that annual wellness checks. There's also community fitness initiatives that can be had, and then public health, whether it's around policy or just a lot of those things. If we have a healthy population, like it's around 50% of the population, what are things that we're doing, whether we're promoting healthy lifestyles, diet and exercise, a lot of those things in that population, as well as making sure that they're not medically homeless and they are attributed to some kind of primary care physician who might be seeing them often, but at least they're aware of them. When they move into a low-risk category or even the rising risk, there's things that can be done. In the low risk, things around screenings. Patients who, turn a certain age might need a colorectal cancer screening or breast cancer screenings. Some preventative measures, whether it's around flu vaccination, pneumonia vaccinations, as we were talking about a little bit earlier. And again, the public health infrastructure you have around that. What are the obstacles or barriers that might prevent us from ultimately managing this patient population? Rising risk, we want to make sure that there's early diagnosis detection that happens. It's part of the family, and we noticed that, there's the diabetes runs across the family, or the genetics around it. Then we can make some early diagnoses or predict some of those things and then prescribe. What are we going to do in terms of to run a scenario out? A patient's been identified as being at risk or even having diabetes diagnosed. We make sure that their HbA1c levels are in check. It could be their weight, things of that, those clinical interventions that we can make, they prevent them from actually moving into the high-risk category. And if they do run into the high-risk category, making sure that there's necessary utilization that is there. A lot of opportunities for quality of care that can be done proactively and preventatively in working with these populations. So this more or less gives you a process in place for which once you cohort those patients, these are the takeaways and thinking, okay, what can I do with them? Question.
One question is, how does this apply to me as an OBGYN? How can an OB stratify their patients?
So perfect. From population health and a lot of these programs, aside from the episodes of care, is that it is really that gatekeeper primary care physician model, which is where a lot of the attribution will occur. But specialists are absolutely included within this whole care team network. So the OBGYNs are included within this in terms of scenarios such as the preventative medicine that can occur, especially in working, with women for their annual checkups and things of that nature. Now, there is all cases where the OBGYN is actually the primary care physician of the patient. But all of this here, you can look at that cohort of your population. OBGYNs also can facilitate mammograms and some of the breast cancer screening. So specialists, whether it's an OBGYN or it's a nephrologist or a cardiologist, they are all the types of specialists in terms of right care, right location, right time. As a primary care physician, we want to make sure, or a specialist, we're communicating with one another. So when we look at these patient cohorts, who are they seeing? A good example of this is I was actually sitting down with the chief medical officer, and he shared with me that the data was all wrong again. It happens to be a regular account because this is the first time that the providers are seeing the data in some detail. And quite honest, a lot of the data out there can often, it's not very accurate some of the times in terms of diagnoses that occur. I was sitting down with the chief medical officer, and he had shared that, well, my patients only go to these cardiologists. So we sat down, we looked through the claims data, and it happened to see that, yes, he was referring his patients primarily to cardiologists, but his cohort of patients are actually seeing about 8 cardiologists that were for them. So in terms of managing the care, as specialists, we can make sure we're talking to and communicating with our network of providers and make sure that some patients are seeing multiple cardiologists. Not that it's a bad thing. We want to make sure that whether it's an OBGYN or even cardiologists or other specialists, there really is that care that is extended throughout the team.
Yeah, we have a couple questions actually. So,
sure.
I'm sure that I don't know that you'll be able to answer this one, but we'll give it a shot. This is a lot of work being done by physicians and nurses. Why does one particular, I think, Medicare Advantage plan pay about half of what a traditional Medicare plan pays for, I think, EM emergency services, office, and well care?
So from the Medicare Advantage, I wish to make sure I understand the question accurately. So from the Medicare Advantage, if I am a nurse practitioner or nurse or any of an MA and I'm billing out, why are my payments less than a primary care physician? I don't have the exact details of the fee schedules, which are included in there off the top of my head. In general, when payers, whether it's Medicare Advantage plans and those commercial payers, or even across the spectrum of the board and other commercial payers, is that there are different fees that are associated with different providers. So primary care physicians or specialists, when there's an E&M visit, are paid at a much higher rate than maybe a nurse practitioner or an MA or some of that other supported staff.
Great. And then what are some of the best and worst practices you've learned while stratifying risk?
So that's an excellent question. So some of the best, and back to that chief medical officer conversation that I had in terms of the cardiologist, that it really is often inaccurate, but that isn't to show that it isn't actionable or it isn't very telling. With mine, when we looked at a cohort of patients that we identified through the claims as having heart failure, the diagnosis on there, we came out, just to put it into relevance, 100 patients who were identified with heart failure. Same with chief medical officer, again, all your data is wrong. These patients don't have heart failure. Drilled down a little bit further to kind of see what was going on with them, and we realized when we actually pulled the clinical information in with those diagnoses that came through a claim, only about 30 to 40% of those patients actually did have heart failure. Their EFs of a lot of the patients was over 40 from a clinical diagnosis. So we went back and forth, and this is where conversation is really key. It's one of those learning points, is that you might have a team who is really good at data and can move it and can say, here's what's going on here with your population, but engage the entire care team around the data to kind of get a lot of those learning points in there. So from that heart failure population, learned that they was also associated with, when we risk stratified them, high cost, high utilization, and benchmark. However, when we wanted to make that data actionable, and that's the most important part of having this data or in having risk stratification, is to make it actionable, like what are you going to do with it, is that when we actually put it in the clinical setting, okay, these patients don't have heart failure, but what are the root causes that are leading these patients to actually utilize this system? Certain providers diagnose them with that or put that on a claim, so that when we put them to care coordination or care management or other extended providers, what are the things that we can help treat that population that are going to be meaningful? So we don't want to put a lot of resources at patients to treat heart failure when they really have an underlying issue that's going on, maybe such as hypertension or diabetes or other things that can exacerbate issues that can kind of cause systemic issues.
Another question that came in that I think is really useful for our practices is, how do you incentivize the staff that you work with to risk stratify patients and to do this work?
That's a great question, too. What we'll often do, and actually that's a really good segue into the next slide here, and I'll answer the question throughout describing this. When we want to take action and implement a workflow, we look at, and this is just a sample, and then follow me here. If we look at, whether it's through a Medicaid ACO, which I know a lot of the programs here in the state of New Jersey are part of this initiative, we want to look at all the patients who might be attributed to that population, and then they become part of the at-risk, at-risk population or patients that are the rising risk. Physician instinct, that's a biggie. That's one of the most easiest things we were talking about a little bit earlier in terms of the physician instinct says, these are the 5% that we really need to go after. We need to actively engage them. We need to make sure they get all their screenings. And we also need maybe some support, whether it's through the specialist, whether it's through social work. Think about those health determinants, whether it's socioeconomic, behavioral health, environmental, diagnostic. There's a lot of different ways to look at it. Going to the question, we're going to put some of those patients in maybe complex care coordination where they're available, whether that's a centralized approach or whether it's even with the office setting, or there's other services that can support that. Moving in the office, how do you incentivize the team? Well, population health, value care initiatives, or reimbursement models, they really are about the extended care team and everyone contributing in that effort. So they can get incentivized. There's intrinsic motivation, and such as KPIs. If we're looking at patient population, what are our end goals? People generally work in terms of, well, if I know my goals, we can actually set some things, whether it's, and depend on the office or the providers or the resources available, to say, if we meet these quality metrics, or we meet our cost of care and utilization benchmarks, our visits per 1,000 are, around 30% of our patients are getting ED visits. Well, our goal is to make sure 20% of them, or 10% of them. So when you take the entire office there, and And it's not just about the provider who sees the patient. It's the extended care team from the people who are boarding the patient, whether it's the nurse practitioner or EMA. They're doing some of those value-based vital signs in terms of the blood pressure and weight, and maybe even doing some of the vaccinations. So they're part of that team. Then there's also the proactive patient management. It's a role which can be part of the office or extended care team, which is called the local care director. They can registry of patients, and they can see, well, who are the patients who are attributed to us, who are the ones who have come in for a visit yet this year, who are the ones who are coming for a visit soon. And they proactively engage the patients, and they can bring them in for a visit. If they have data with them, whether it's through a technology solution or there is still some providers who are on paper system, they're aware that they're a diabetic patient, for example. When they call up the patient for a scheduled visit, they say, hey, listen, we can actually go get your blood work done. We got a script for you. We'll sit out, go get it done. So by the time you come into the office, we'll get results, and then we can manage you that way. From a paper perspective, that allows them to not have to come in the office twice, pay 2 co-pays, take work or whatever it is that in the day there, they come in once, they get treated, and they go out. So you're incentivizing the staff by being a part of that team who is going to reduce the cost of care, reduce utilization, and then those possible outcomes. And if there is certain Medicare Advantage programs or shared savings programs, then with that in mind, the way to incentivize them there through their savings payments. So, for example, if there's a benchmark for a patient population and the total spend for that year was $1 million, so that's the benchmark based risk adjusted and everything else. If at the end of the year, instead of being $1 million, it was $100,000 in total payment for that population, then that means there's $100,000 in shared savings. We're actually seeing in practice and working with a lot of providers that they'll incentivize the staff, not just the providers who take in part in the $100,000. It actually gets distributed to anyone from this local care director to the MA or the RN, and ultimately the provider or the practice for which one is incentivized for that outcome and really been part of that team. So, in sports analogy, everybody wins or everybody loses. So, scenario, $100,000, everyone's getting a bonus of that payment. It can also be reinvested into other things. So there's that financial motivation, to sum it up, and there's also some of that intrinsic motivation. That's good to feel part of the team. It's good to see goals, and especially with a lot of these practices providers knowing their patients, it's good to see those positive outcomes. End of the day, we can all win with a little bit of financial incentive, being financially incentivized at the end. So moving on, the scorecard, and I'll go through this a little bit quickly, but this is just a sample scorecard. It's something easy to do. Can even do it on paper. Can do it on a whiteboard if it's in your office or location. You can put it in an Excel spreadsheet. But look at our patient types here again. They're in 4 major categories, and we're going to know how many of the patient populations are actually in there. Then we have the number of patient contacts. That can be one of your key performance indicators or KPIs. The at-risk population, you probably want to contact them monthly. They don't necessarily need to come in monthly for a visit. Some of them might, but whether it's through a phone call, whether it's through mailing, just something to make sure that you're continually engaging them and sure if they are, that they don't end up in a hospital necessarily or end up in terms of an emergent episode. Risk, maybe you want to see them quarterly or contact them quarterly, and then so forth. You can even see down to the semi-annually or annually. So you want to set those goals, you want to work towards them, and ultimately these goals should be in line with what your ultimate contractual commitments are or performance is based on that contract. It could be based on just the quality performance, cost of care, and ultimately it could be that financial motivation factor through which you can monitor, measure, and then adjust accordingly so you meet those goals at the end of the year.
Bryan, we have a question that's somewhat related to that, and I think a lot of our providers are really acutely concerned about MACRA and MIPS and the program that they're currently working towards improving their quality and reducing their costs. One question that we had was, should we categorize all of our patients into risk categories and work that way, or just focus on a smaller subset of Medicare patients since we're focused on reporting to MIPS?
So that's an excellent question. So I'll give you the global answer. It should be everybody. because in terms of MACRA, and that is specific to EMS, where they're actually pushing towards 80% of all payments will be based on value, whether it's through the MIPS, which most providers, there's certain thresholds which some providers aren't going to be eligible for it, for the compliance of some of the reporting. But most providers that bill those Part B payments are going to fall into MIPS, but there's also alternative payment models and advanced alternative payment models. We won't specifics or details here. Maybe we'll save that to the end because it can get a little detailed. But as part of that Medicare population, there are reports out there that are publicly available. I would suggest that any provider actually go online, CMS website, and maybe we can follow up afterwards. I can help direct people to it, and get your QR/UR reports. Those reports will tell you as a provider the patients that were attributed to you and what your performance looks like. It's very valuable information. It's great intel, and it gives you an idea on what your cost of care utilization benchmarks are going to look like, as well as what type of targets do you have.
And NII is actually going to help all of our practices get their QR/UR reports on their behalf.
Excellent. That I would suggest, whether it's a Sunday morning reading, or you just want to do it when you're sitting at a ball game or something, it's definitely valuable information, and it's going to be really good for you to details of it, because ultimately your payment's going to be based upon it. Getting back to that, though, yes, you definitely want to get the information you got for your Medicare and the macro world, because your payment's going to be based upon that. But a lot of the commercial programs across the United States are actually moving in that direction, and a lot of those programs. On the front, just to bring this up, because it's pretty good timing, a lot of talk around repeal and replace. I just wanted to share that in both chambers of commerce as well as health representatives, there was 92% approval in both of those. So either there might be a repeal and replace. The MACRA, this value-based payment world isn't going away. The ship has sailed. So for all providers, I would suggest that if you haven't jumped on yet, you might want to get in a rowboat, catch up before it really heads out in the middle of the sea. So, bring home a little bit. This is a real use case that we use for risk stratification. What it was a 77-year-old female who stratified or risk stratified in two areas. We were able to look at the claims data, and we knew that this patient had a combination of CHF, COPD, hypertension, and diabetes. Now, among other things, but these are kind of the big four that this patient had. If we even didn't have claims data, we could have gone on the patient chart and saw what they had. What we did here was we didn't need super advanced tools to even find this out. Is that this patient came from physician instinct when we were reviewing the list of patients with a provider, and they said this is one of those patients in the top 5%. They had big four. Months later, and this patient was actually placed into care coordination, where there was active and proactive patient management. Think about that monthly touch point, whether it's phone calls or getting them in the office, things of that nature. This patient, about halfway through that, ended up had an acute episode. They needed a double bypass. In addition, once they were out of the hospital and during cardiac rehab, the patient actually became homeless. A social worker was arranged. There was extended care and housing, and to give you kind of the end of the story, the patient was able to find a new home. Now, the results over a 12-month period or over a year, the patient only having a length of stay of 10 days, and that was for the double bypass. They have any readmissions, and they have any ER visits. So you see here, and looking over the right-hand side from the cost of care summary, when we use those advanced tools, the risk of this patient was 53.8. Now, to get a relative standpoint, it's relatively high. Most patients, or not most patients, but if you think of that healthy population, they can stay, in a couple points. The real high-risk population or at-risk population, they can be anywhere around the 70, 80, 100. Depends on what the threshold is. But the risk score here, the highest we had for a patient was around 90-something. The total cost for that patient for over a 12-month period, those, 4 comorbidities, diagnoses, along with the double bypass and the admission, was $80,000. The benchmark for that patient at the time was $30,000, so they were $50,000 over benchmark. What it means is that, we want to prevent the patient from needing a double bypass, didn't see it coming, life event happens, and they're in the hospital. But based on that utilization, the mitigated cost there, this could have been 3 or 4 times more in cost for that patient if they had been readmitted multiple times, or in the emergency room multiple times. So it's helped us facilitate that physician instinct, the extended care team, whether it was through the AAs or the nurse or the nurse practitioners, or even the specialists, whether it was the cardiologist, the nephrologist, things of that nature, and even care coordination. We were able to prevent a lot of unnecessary spend or that overutilization that we were referring to a little bit earlier in terms of maybe the 15-30%. This patient would have been 3 to 4 times more spent on an average from what we've seen in our data.
Another question.
Sure.
Just a reminder to everybody, if you wouldn't mind, when you send in a question, send it to all participants so that everybody can see your question, but I'll read them as well. Really good question. So what do you do with a patient that refuses to or doesn't agree with what's being done to bring down the cost of their care? Do you discharge or report or just take the hit on your QR report or your treated patient?
Yeah, so that's a great question. So me personally, I'm not a provider, so I don't do anything with them. But what we do suggest, because we do get that a lot, when you see your attributed list of patients, sometimes we'll get, and let's just say there's 100 patients on the list. Who are these 10 patients? Never heard of them before, never seen them before. So it really comes down to understanding why are they even being attributed to me. There could be commercial rules such as the patient just selected you as their primary care physician. So if in that scenario they select you and they're non-compliant, you have the ability to go back to the healthcare plan and say, hey, listen, this patient's non-compliant, they're out of office, can you please attribute them to somebody else or ask, and then the patient will get a letter or a phone call and say you need to select somebody else. In Medicare world that we've experienced so far, especially with the MACRA, it's going to be based on total charges, total Part B charges or payments providers will receive. There currently isn't a mechanism in place for which to dispute that patient if you're still continuing to see them. So from a compliance perspective, and I don't know all the details on this, but there are certain processes in place for when you want to discharge a patient. If they are non-compliant, then you're going to want to move them to somebody else. Hopefully, fashion where they're not medically homeless and they're bouncing around the system. But there are patients that are going to be on your panel, and that's why it's really important that you go through your QRUR. You're going to want, and you want to look at your overall patients that you might be seeing, whether you got it through a claim set or whether or not you even just look at your patients on your panel who you've seen in the last 12 months, whether you get through your billing system or you just look in your EHR to see who those patients are. And then when you run down that list, and that's where it really starts, and where we started some of this conversation, was around who are your patients and why are they attributed to you. So if there are patients who are non-compliant, and they're just going to end up fouling up all your numbers and you tried everything you do, it's really that fine line. There really isn't a good answer to it because you want to make sure that these patients are being helped somewhere, somehow by somebody. Be cognizant of the fact, whatever you do, that you ultimately, they could reflect your numbers. I get this question asked a lot, and it's a tough answer because you don't game the system and you treat the patients who are compliant, need to say. I'm actually talking to a provider about 2 or 3 weeks ago, and he's having the same issue with the patient. And it's a patient who will even listen to their family. They're actually bipolar, have some behavioral health issues. But he would find that and this is something that really resonated with me, is that he doesn't want to kick them out of the practice because someone else might not be able to pick them out. He doesn't want to make it somebody else's problem. So some things you can do there is to find, well, what are the certain things that you can actually activate with that patient. If you think about that, there's activation measures. It came down to her cat. When he's talking about her cat, that was the way to engage her. And he even talked about some simple things, is that maybe send a note to that patient, a card, and saying, hey, listen, and writing a little message and saying, thinking about you and your cat. Like, just simple things that might sound funny, but there is often ways to break through people. And, I mean, it was simple as, she want to talk about her family, it's about her cat. So, I'm going to answer to say, there isn't a great one there. You want to ultimately try and activate them. but you want to think of the systems and processes in place for which to discharge them, because they can affect your financial outcomes, your quality, performance, and anything you're getting judged against for payment. To kind of close this up here, it's just a funny way of looking at, what's the data all about? As a provider, anyone on the extended care team, get to know your data. In terms of scenario, and I've brought it up a few times, I'll often get all of your data inaccurate, and this cartoon here is, are you sure the data you gave me is accurate? The answer is, I've been giving you incorrect data for years. This is the first time you've asked. And then the response is, what? The data is totally accurate. So it shows you don't want to have that disconnect between people who are sitting behind computers, coming up with your reports, your data, really engage with it, understand it, continue to question it, but continue to question it with a watchful eye of, well, you know what, maybe it's not inaccurate. It could be accurate, but if you get to the point where you actually validate it's accurate, then you start asking the why, whether it's the descriptive and some of those items we went through earlier, so you can predict the future. The things that we learned here in getting to know your data is really identifying the difference between the signal and the noise. There's a lot of data out there, a lot of things you get on patients. Some of them can be total noise. You really want to try and find and focus on the true signals that are going to actually activate a patient and optimize their care. Think of the scenario we talked about with the CHF. There was noise in that data, but it was a signal for high cost and high utilization. So really understanding the root cause for how we can help these patients. So with that, we can conclude.
We have some questions on the chat box, but Fran, maybe you want to ask folks how they can, or let folks know how they can ask questions by opening their lines.
Sure. So we can continue answering questions in chat as we've been doing. Reminder to all participants, if you can, that option was showing up. It should be showing now. You just need to scroll down below the list of on there. If you'd like to ask a question over the phone, please click the little hand symbol, and that will indicate to us that you would like to ask a question, and we will unmute your line.
Okay, and I'll start out with some of the questions we've got in the chat box here. What are some low to no cost tools that a practice can use to employ a risk stratification methodology?
Okay, so low cost is number one. Let's assume you don't have any claims data on your patients. I alluded to a little bit earlier. If you can your billing system, that patients that you've seen, or through HR somehow, list out your patients. You can even get it on a pad of pen and paper. Don't even have a computer, let alone something like Excel to do it. And go through that entire list of patients. Well, here's my unique patients that I've seen over, I would usually go back a 12-month period. If you have the time to do it, I would actually go back 18 months because there are some patients you might not have seen in that. And it actually depends on the type of provider you are, whether you're a specialist or primary care physician or even a pediatrician. Because, a lot of these populations, and don't want to dismiss that one either. Let's get out a pad of pen and paper, let all of your patients that you've seen in the past, year, maybe even 2 years. Wouldn't go back much further than that unless you had a reason to do it. Put them out and put them in those primary buckets. There are advanced technology out there have way more than 4 buckets, but that's a good 4 to start with. Whether you're healthy, you're all the way up to your rising and at-risk patient, and really put them in those buckets. And you can come up with that scorecard that I presented a little bit earlier and say, what are we going to do with these patients? So how do you put them into your buckets? Instinct. That's really the first way to go about doing it. If you know your patients, you know them well, you're able, and I've learned this in working with and talking to a lot of providers, they're able to do it very, very quickly. It really does amaze me every single time. If you're a little more advanced than that, then you actually just add another column to that. You see, list your patient's names, actually give them each a score, and I rate it on 1 to 100. And 1 being, here's how I would weight it here. A 1 would be, fairly healthy in that category. And I have my patients who are really in that at-risk or highest at a score of 100, and then score them on that, and then you come up with your scenarios.
Another question on the chat box is, are there any templates available for comorbidity questions to ask or suggest, like how you would ask a patient what kind of comorbidities they have?
So that appears on more the clinic side. I will tell you that there are the patient activation measures, or the PAM score, and that's a good way to see whether your patient's going to be compliance or engaged in their care. That one, I believe, it is actually at a cost, unfortunately, but there are other things that are similar to that. That's why I just mentioned the patient activation measure that you can actually, Google or look up and you can find. On comorbidities, depends on whether, if it's in your EHR and you see a patient, you usually have them on there. If you are on a paper chart system, there are templates that you can make up. I don't know of any off the top of my head that are out there, but it's more of a workflow type of a question. You want to integrate that in your workflow and how you're going to document them. Come off of anything in terms of something as simple. If you want to create a template, what are the common, and providers are different, but my population, the patients I see, what are common chronic diseases or diagnoses that I see, and almost create checkboxes. And that is to do it.
Great. Do we have any folks that wanted to open the line and ask questions?
At this time, let me do a check. No, not have any hands raised at this time.
Okay, one of my own. So how can identifying and stratifying patients increase a practice's efficiency? I think we're talking a lot about these value-based programs and working towards higher quality and lower cost, but for the practice itself, how can they become more efficient by stratifying their patients?
This really goes back to, what is population health? It's really ensuring that patients receive the right care, right location, at the right time. That's part of the preventative to the acute, the post-acute world we're talking about. So it's really, in terms of that efficiency there, it's the holistic care as opposed to episodic. So some easy workflows that you can integrate in your practices. And we talked about a little bit earlier in terms of that model where there was a local care director. Anyone even at the front desk. They don't need to be clinical, but those are people who can proactively reach out and engage patients, and they can get them their blood work ahead of time or order that script for them. The patient actually comes in, certain things that the person, if you have someone on your team who can board the patient, whether it's an AA or a nurse practitioner, they do a lot of the things that the providers may have historically done. Anything from giving vaccinations and doing some maybe even medication reconciliation. Then or even doing the episodic care. Patient comes in with bronchitis. There's certain things that they can do there. Then patient actually sees the physician. That's more complex patient management. It's chronic diagnoses or things that they can treat. So it's really around workflows. Who's the appropriate person to be doing certain work within the practice setting or office? And then also ensuring that you're continually engaging your patient population. Some others, if you think about those 4 categories again, you're going to do some people annually. There's other people are going to be more constant, whether it's monthly. So there's some patients you can be on daily and weekly. But it's the efficiencies there are really gained from the extended care team. Who are we're not on this island alone anymore. It is an extended care network. And back to even the specialist question. How can we utilize our specialists and create them as part of the care team, whether it's the OBGYNs or radiologists or all the other types of specialists?
Great, thank you. At this time, I guess I'll ask if anybody has any final questions. If you want to put them into the chat box, or if you want to raise your hand and ask a question verbally, Fran can unmute your line. And see if there are any additional questions. I wanted to mention our next webinar is on December 13th. We're going to be talking about population management with Dr. Kolesk from Virtua. No additional questions on our end. I want to thank Continuum Health Alliance and Bryan Wellens for doing our risk stratification presentation today. And actually, we just saw another question come in. Kathy Kathy, I'm not sure we understand your question. If you wouldn't mind retyping it in. It's not coming over clearly. So our last slide here is our contact information, myself and Fran Griffin, our Senior Program Director. If you have any follow-up questions after the presentation, I'm sure Bryan would be more than willing to answer your questions by contacting myself, contacting Fran, or contacting Bryan as well. And one question, are there any risk stratification methodologies that are tied to return on investment for the practice, or how would you tie quality improvement from risk stratification to return on investment?
Thanks, Tyler, and the team here today. It's been really great and an engaging conversation. Well, in the risk stratification methodologies that are tied to ROI practice, about this in a global perspective, a lot of value-based payment models are around risk stratification. That's how they come up with the benchmarks for the cost of care for your population. Higher risk score is obviously going to be associated with a higher benchmark and vice versa. So when we look at the return on investment for the practice, we want to look at the things that you might be, your costs that are associated with it. For the practice level in the ROI, if payments are coming in fee-for-service plus the value-based payments you might be getting, you want to look at all the revenue associated that you're bringing in your practice. If you're bringing in, I'm making the numbers up again, $100,000, then your return on investment is going to be any of the costs you have associated with that or you're putting into these programs. So the risk stratification methodologies there really comes down to the total risk of your patients. That comes up with a cost of care benchmark, and either going to be above or under that.
One more question, and I think I'm going to try to understand it. So from Kathy, we repeat PAPs as a matter of course on patients every 6 months due to social aspects. Would doing more than is the standard have a negative impact on our performance? I mean, that's a really clinical question. So we may hold off on that one. But thank you, Kathy. I think if we can get you an answer offline, we'll definitely reconnect with you on that. So seeing no additional questions, thank you to Fran from the Garden Practice Transformation Network and to Continuum Health Alliance for co-hosting today's webinar, and to Bryan Wellens for being our faculty for today. Thank you, everybody, for joining and for participating in our second webinar in our monthly series.
This concludes today's webinar.
Thank you.
Goodbye.